In this presentation, we're going to look closely at the drugs for Alzheimer's disease. Alzheimer's disease is a devastating illness. It's a progressive neurodegenerative disease that is the most common cause of dementia. We will see progressive memory loss, impaired thinking, and neuropsychiatric symptoms like hallucinations and delusions. Many patients with Alzheimer's disease actually have the inability to perform their routine daily tasks, like their activities of daily living. In the US, there's over 5.5 million Americans who have been diagnosed with Alzheimer's disease, making it the sixth leading cause of death in the US. And on average, annually it costs 277 billion healthcare dollars. Even though we have pharmacologic treatments like the use of cholinesterase inhibitors, which we talked about in our lecture regarding the PNS drugs, we also have N-methyl D-aspartate receptor antagonist memantine. Now, there is no cure for Alzheimer's disease at this time, but the pharmacological treatments that we have can provide modest improvement in some patients. So, what does this mean? All the neuronal damage that occurs with Alzheimer's disease is irreversible. Remember, we can't cure Alzheimer's disease. And so the drugs that we use currently can help relieve symptoms to prevent neuronal loss, but many patients that use these therapies are not going to see a significant delay in the progression of their disease. So, really quickly, outlining the pathophysiology of Alzheimer's disease, we know that this neuronal degeneration occurs in the hippocampus and it occurs very early in the process of Alzheimer's disease. And many times, these brain changes can occur, but we may not see any outward symptoms. Later, we're going to see degeneration of neurons in the cerebral cortex and a subsequent decline in the cerebral volume overall. So, what's important about the hippocampus? Well, the hippocampus serves as an important role in memory. So, once the degeneration occurs, we start to see the signs and symptoms of dementia and memory loss. The cerebral cortex is our center for speech, perception, and reasoning, and our higher functions. And this is why you see the challenges with hallucinations, and you see the challenges with being able to perform daily activities of living. As the hippocampal neurons degenerate, we will first start to see short term memory loss. And then over time, as the cortical neurons degenerate, we're going to see patients with difficulty speaking. They have difficulty with language. And in the advanced stages of cortical degeneration, the more severe symptoms will start to be apparent. We might even see the complete loss of speech with some patients, loss of bladder and bowel control, and now a complete inability for self care. Alzheimer's disease eventually is going to destroy enough of the brain function that it will cause death. In patients with the advanced disease, levels of acetylcholine are 90% below the normal levels. And why is this important? Well, without acetylcholine, we lose that important transmitter in the hippocampus and the cerebral cortex. And this is where the neuronal degeneration occurs. Secondly, acetylcholine is critical to help form memories. And when we start to have a decline in acetylcholine, this is being linked to the memory loss. However, cholinergic transmission is essentially normal in patients with mild Alzheimer's disease. So once it goes from mild to advanced, it really does significantly change the amount of acetylcholine. There is a connection there. The loss of cholinergic function cannot fully explain the cognitive deficits that occur early in the disease process, however. Let's continue our conversation regarding the pathophysiology of Alzheimer's disease. And there are some hallmarks to this disease. The first one being neuritic plaques. They form outside of the neurons, and these are spherical bodies that contain beta amyloid, which is a protein fragment. It surrounds, is surrounded by neuron remnants. These plaques are seen mainly in the hippocampus and the cerebral cortex. And patients with Alzheimer's disease, we know that they are going to have very high levels of beta amyloid. We also know that accumulation of beta amyloid actually begins very early in the disease process, even 10 to 20 years before we see any outward symptoms. So, with this understanding, beta amyloid appears to play a very central role in the treatments that we try to use against Alzheimer's disease. We are directing it against beta amyloid production or development. The next thing, or the next prominent feature, is going to be the neurofibrillary tangles. And these are um, just like the neuritic plaques that we talked about earlier. They are very prominent in terms of Alzheimer's disease and identifying the disease. So, unlike the neuritic plaques and the beta amyloid, these are going to be formed inside of the neuron itself. When these tangles are formed, they actually are disrupting the very orderly arrangement of microtubules that are inside. And because of the tau protein causing a healthy neuron to become tangled up on itself, we will actually see tau twists, which are causing paired helical filaments forming the tangles. And so it's taking what should have been orderly and now tangling it all up inside the neuron. There are some other considerations for Alzheimer's disease, like the role of apolipoprotein E4. And we know that this plays a role in cholesterol transport, but some scientists believe it contributes to Alzheimer's disease as well. There are several forms of apolipoprotein, but it's the ApoE4 version that is associated with Alzheimer's disease. And geneticists have seen with individuals that have had Alzheimer's disease one or two copies of the gene coding for ApoE4, putting that patient at more risk for Alzheimer's disease. Yet, there are people with Alzheimer's disease that do not have this gene particular um, as well. So, again, to synthesize that, patients with Alzheimer's disease can have ApoE4, but not all do. Next is the endoplasmic reticulum, and there is an endoplasmic reticulum associated binding protein, or an ERAB, which also presents in high concentrations in some patients with Alzheimer's disease. And what is believed is that the ERABs enhance the neurotoxic effects of the already existing beta amyloid. The last is homocysteine. And with elevated plasma levels of homocysteine, we have seen an increased risk of Alzheimer's disease. Now, fortunately, we can reduce this risk. This can be modifiable if we can lower the levels of homocysteine in our patient. And this is by eating foods that are rich in folic acid, vitamin B6, and vitamin B12. And luckily, we have dietary supplements that can help with this. There are major risk factors like advancing age and family history. In 90% of patients with Alzheimer's disease, the age of onset was about 65 or older. And the risk of acquiring Alzheimer's disease after that increases exponentially. It actually doubles every 10 years until they're about 90 years old, and then it starts to level off or decline. The only other known risk factor is family history. Yet, being female may also be considered a risk factor, but the incidence really is kind of not supported very well. A suggestion is that women just simply live longer than men, and this is why. Other positive risks, or excuse me, possible risk factors that have been studied are head injury, a lower educational level, again, talking about the production of apolipoprotein E4, high levels of homocysteine, having low levels of folic acid, being on estrogen and progesterone therapy, having a sedative lifestyle, smoking, and chronic exposure to secondhand smoke as well. And we're talking about nicotine. In addition to the symptoms that we've already discussed, I wanted to also bring out the behavioral changes. Sometimes you'll start to see patients wandering or pacing, they become more agitated. You start to see them become more agitated, specifically in the later evening time or sundowning. In the final stages of Alzheimer's disease, patients are unable to recognize their close relatives and friends, and they may lose the ability to communicate at all. These symptoms typically begin after the age of 65. And this is why we said earlier that we usually start to see the symptoms at 65, but doesn't mean that they didn't have the disease, for the last 10 or 20 years. Some patients, we might even see symptoms as early as 40 years old. The life expectancy, unfortunately, from symptom onset to death is about 20 years or more. However, for most cases, it's about 4 to 8 years. And during those latter years, they will be in the advanced stages of Alzheimer's disease. Now, although there is no clearly effective therapy for the core symptoms, we may also be able to treat the other symptoms that occur from that loss of function and loss of self care. So, we might be able to not only prescribe um, the CNS drugs or the PNS drugs, we might also be able to help with incontinence and depression. This algorithm is important in helping you to decide what type of drug you are going to use. And with mild symptoms, we can start with the cholinesterase inhibitor and then reevaluate in 2 to 4 weeks. If this continues to work and the patient is tolerating the drug well without any adverse side effects, then we can continue again and follow up in about 3 to 6 months. If there are some side effects, we might change to a different cholinesterase inhibitor, or we may decide to continue the plan a little bit longer to see if we might have a better efficacy over just a little bit more time. But if conditions deteriorate, we are going to start now treating for moderate severity Alzheimer's disease. Once we get to the moderate level, and this is when patients will also now have difficulty with activities of daily living, and they're going to start to have more anxiety and agitation, and they start to have difficulty recognizing family members, we may move now to the cholinesterase inhibitor and include memantine. And this is true with the severe treatment of Alzheimer's disease as well. So once we progress, we are no longer just using the cholinesterase inhibitors. We are going to also consider using memantine in addition to the cholinesterase inhibitors. We're going to have them follow up in 2 to 4 weeks and then again continue treatment to see if we see any change or improvement, and they will return in about 3 to 6 months. Now, if we don't see any change or improvement, we can again alternate the cholinesterase inhibitor if that's the problem. And if conditions are still unimproved, um, even if memantine was used and they're not getting better, then we may just have to discontinue the medications altogether because at some point we are looking at the risks and the benefits. Now we're going to talk specifically regarding the drugs that are going to help with the cognitive impairments of Alzheimer's disease. And remembering that the goal here is to improve symptoms and reverse the cognitive decline. We can't cure Alzheimer's disease and reverse the tangles and the beta amyloids and the tau proteins. Now, currently, these drugs can't do this. So, instead, we have to focus on slowing down memory loss and cognition, prolonging independent function, and in some cases, even, modestly seeing an improvement is going to be elusive. Remembering from earlier on in the lecture, I said that not many patients see a big improvement. But for those families that are willing to try pharmacological treatments, what has been approved are the cholinesterase inhibitors like donepezil. We also have talked about rivastigmine previously. This is a drug that we also use for other chronic neurologic illnesses. And then we can use memantine. And what memantine will do will block the neuronal receptors for N-methyl D aspartate. Table 20.2 shows you how these drugs are prepared in terms of the doses and what you might want to use it for. So again, mild to severe, we can use Aricept or donepezil, which is a cholinesterase inhibitor. And we might use this for a mild to moderate Alzheimer's disease, um, for the symptoms of mild to moderate Alzheimer's disease. And we might use 5 milligrams daily. Now, once it gets severe, we can up this and double the dose to 10 milligrams daily. And you can see that there are other cholinesterase inhibitors like rivastigmine, and we can also use galantamine as well for mild to moderate. Memantine, remembering that this is when Alzheimer's disease has now become moderate to severe and we've used the cholinesterase inhibitors, we're not seeing much effect or we want to see more improvement, then we're going to now add memantine to their therapeutic protocol. In table 20.3, you can see the pharmacokinetic properties. These drugs are all prescribed mostly PO route, but rivastigmine has a transdermal patch that can be taken as well that peaks at about 8 hours. They are primarily excreted through the urine, but with the cholinesterase inhibitors, there are a couple that can be excreted through the feces and the bile as well. You note here also the hepatic metabolism that occurs. So with most of these drugs, you're thinking about the CYP 450 or the 2D6 or the 3A4. And lastly, with rivastigmine, primarily it is metabolized by this acetylcholine esterase in the brain. So let's look more specifically at these drugs. We'll first start with the cholinesterase inhibitors, remembering that they were the first drugs that the FDA approved actually for Alzheimer's disease. And the three that are available are donepezil and galantamine and also rivastigmine. We'll start with donepezil or Aricept. This is for mild, moderate, or severe Alzheimer's disease, and it's going to cause a reversible inhibition of acetylcholinesterase. And this is more selective for the acetylcholine esterase that's actually found in the brain. So we're not really talking about the PNS, we're talking about the CNS here. Like the other cholinesterase inhibitors, donepezil isn't going to affect the underlying disease process. It's not going to cure Alzheimer's disease. We also know that it's highly protein bound, which means that it has a prolonged plasma half-life of about 60 hours. And according to the FDA, it takes about 15 days for donepezil to actually achieve a steady state and for patients to start to see improvement. It is somewhat selective for the brain cholinesterase, and it can cause, however, still peripheral cholinergic effects like nausea and diarrhea, which are the most common side effects of these drugs. Additionally, donepezil can cause bradycardia, fainting, or fall-related fractures from fainting, etc. To minimize the effects, we want to stabilize the patient on the initial dose for the first 3 months before even trying to increase the dose. With galantamine, we also know that this is a reversible cholinesterase inhibitor, but we use it for mild to moderate Alzheimer's disease. And what's interesting about this drug is it's prepared by extraction from daffodil bulbs. In the clinical trials of galantamine, we've seen improved cognitive function. We've also seen improvement in behavioral symptoms, quality of life, and the patient's ability to perform their ADLs. However, just like the other cholinesterase inhibitors, the benefits are pretty modest, and if we do see benefits, they're very short lasting. Like Aricept, the most common adverse effects are nausea and vomiting, but we also might see diarrhea, anorexia, and also galantamine may cause some weight loss. The nausea and other GI complaints, though, are going to be greater than we see with the Nepozil or Aricept, but it's going to be less than rivagastamine. So it's kind of in the order of GI disruption, being the Nepozil being the least amount of symptoms on the GI system, galantamine being more than the Nepozil, and then rivastigmine being the most. We also know, like other cholinesterase inhibitors, that we might see bronchoconstriction. And so, with patients with asthma or COPD, you might not want to prescribe these medications because drugs that block that cholinergic receptors, just like we talked about last week, like the anticholinergics, the first generation antihistamines as well. Some TCAs can also do this, and other conventional antipsychotics. Um, can reduce the therapeutic effects. So we want to avoid those drugs when we're using these drugs. Lastly, with rivastigmine, uh, we will think about in terms of its side effect profiles. We're going to see even more common cholinergic effects, even enhanced nausea, vomiting, and diarrhea, abdominal pain, tremors, and we see that loss of appetite or anorexia as well. Weight loss becomes a problem more so with females than men, but we will see weight loss in both. Because we are enhancing that cholinergic transmission, this drug intensifies the symptoms like peptic ulcer disease, bradycardia, urinary obstruction, lung disease. So, with patients that already have those disorders, we want to be extra cautious, especially with rivastigmine. Like other drugs in this class, we might see the bradycardia, fainting, falls, and fall related fractures as well. So, overall, they all have the same type of side effect profile, but rivastigmine just has a little bit more of risk for those side effects. Now, moving on to memantine. Memantine is pretty well tolerated, but remembering that we don't bring this on until we have severe symptoms or moderate to severe specifically. And we are using this in addition to a cholinesterase um, inhibitor. And for many patients, this drug will have modest benefits. We can slow down the decline in cognitive function. We might also be able to improve some of the behavioral symptoms. But overall, we know that it's not going to cure Alzheimer's disease, and we are going to see some modest effects. Now, studies have shown that using memantine plus donepezil has been more advantageous for moderate to severe Alzheimer's disease than just using donepezil alone. So, what the study is telling us is that the two agents confer independent benefits, but they can also act synergistically to enhance each other's effects. Overall, the mechanism of action for memantine is the modulation of how glutamate affects the body. Glutamate is a major excitatory transmitter in the CNS, and it works at the NMDA receptor. And remembering that the NMDA receptor is a transmembrane protein with a central channel, it regulates calcium into the neurons and it plays a critical role in our ability to learn and our memory overall. When we have the binding of glutamate to the NMDA receptor, this is promoting that calcium influx into the neuron. So, in healthy individuals, an action potential will release this glutamate into the synaptic space. And it binds with the NMDA receptor. It's going to displace magnesium from that receptor channel blocker, move that magnesium out so we can get calcium inside. Then it's going to quickly disassociate from the receptor, now allowing magnesium to come back and gatekeep that channel. This is going to prevent more calcium to come in. That brief period where calcium was able to come in because magnesium moved out of the way, this is a signal. And this is what we talk about in terms of a signal in the learning and memory process. So that's all under healthy conditions. But what happens under pathologic conditions? Under negative conditions, there's a slow but steady leakage of glutamate instead of that major burst of glutamate. So we have just a little bit all the time. And this is leaking at the presynaptic neuron and surrounding a glia space. And as a result, that channel in the NMDA receptor is just always kept open. And when it is kept open, it allows too much calcium to come inside. So why is this a problem? With high intracellular calcium, there are two effects. We have impaired learning and memory because there is too much, quote, noise created by this excessive calcium, and it overpowers that signal of learning and memory process. So calcium is negative to our ability to learn and our ability to remember. This is created by too much calcium entering that space in response to the glutamate just being released all the time at that nerve impulse. And this is going to also, in conjunction with overall neurodegeneration, because the intracellular calcium is just too toxic for this environment overall. So then how does memantine work? Memantine, it says it's a neuronal receptor blocker. So memantine is actually going to block that calcium influx into the extracellular space where that glutamate is. It's going to get to the NMDA receptor before glutamate can, and it's going to now permit calcium from going into the extracellular, into the space. And it's not going to allow that influx of calcium into that channel. When glutamate levels are low, memantine is going to occupy that NMDA receptor channel, blocking that steady state of calcium entering that channel. So what do we have as the net result of this action? The level of intracellular calcium is now able to normalize, and when we do get a burst of glutamate being released in response to an action potential, that high level of extracellular glutamate is able to displace memantine, which then is going to cause just a brief period of calcium entry. But because intracellular calcium is low now, that normal signaling then can occur. When glutamate eventually diffuses away from that receptor, memantine is going to now reblock that channel and thereby stop further calcium entry from occurring. We're able to keep low levels of glutamate in that synapse. So all in all, glutamate is causing a negative effect within that channel with patients with Alzheimer's disease. When we prescribe memantine, remembering it is for moderate to severe Alzheimer's disease, and often we're using it with donepezil or another cholinesterase inhibitor, the most common side effects are dizziness, headaches, and confusion, although this usually happens to less than 7% of patients taking the drugs. It really is a well-tolerated drug. But there are other common side effects, less common than dizziness, headache, and confusion, like diarrhea and constipation that can occur. Now, this is different than the cholinesterase inhibitors. There are rare skin reactions. But these rare skin reactions can cause some big events. You might want to watch out for Stevens-Johnson syndrome. You might also want to watch out for erythema multiforme as well. Taking memantine may cause cardiovascular events like bradycardia, hypertension, and angina. We've seen that in some patients. And also, you might need to adjust the dose for renal impaired patients. So, anyone that has a creatinine clearance of less than 30 milliliters per minute may need a half dose of memantine. In terms of drug interactions, in theory, if you combine memantine with any other NMDA antagonist, like ketamine, you could have an undesirable effect because it would be an additive effect. You're having two of the same type of drug working against the NMDA. So you want to do that with caution. Also, sodium bicarbonate and other drugs that have an alkalizing effect um, can greatly decrease the renal excretion of memantine. So, what will result is then now there will be an accumulation of drugs inside the renal system, causing toxic effects. Okay. Lastly, in prescribing memantine, there are some goals to consider and then things to remember. The goals are that we are only going to use this drug until we see that the risks have outweighed the benefits. We're also going to remember that our overall goal is to slow down the cognitive and functional decline of patients with moderate to severe Alzheimer's disease. We also want to remember that at baseline, we need to know where our patient is cognitively and functionally. So we have to get some baseline tests to determine their state of new learning and their cognitive state overall. We also want to monitor their functional status and cognition at each visit as we follow up. The high risk patients are going to be those with cardiovascular disease, hepatic or renal impairment, and also any type of ophthalmic disease or eye disease. Minimizing the adverse effects are going to be dizziness, that is very common. And so we want to decrease that risk of fall for our patients because we know that then falls will hospitalize most patients, and there are a whole list of risk factors associated with that at our later age. We advise patients to take acetaminophen instead of NSAIDs for headaches with memantine because there could be some adverse effects with taking the drugs together. And finally, the last two slides are a good way to sum it up and to review, considering your key prescribing considerations and patient education here for cholinesterase inhibitors. So please take a moment to pause the video and read and test yourselves on these points. And also the next slide. Here we're showing the summary of key prescribing considerations and patient education required for the prescribing of memantine. Please again take a minute to pause the video or your slide deck to review this before the exam.